Let's bring in Professor Kogie Naidoo, the Deputy Director and Head of TB/HIV Treatment Research Program Centre for the AIDS Program of Research in South Africa. A very good afternoon to you, Dr. Kogie. Thank you for your time with us here on the SABC.
Good afternoon, and thank you for having me on.
Prof, let's talk about TB and HIV and AIDS co-infections, the reality on the ground, given the mortality and infection rate.
So in South Africa, we have approximately 300,000 patients with tuberculosis. Of these, at least 59% of patients with tuberculosis are co-infected with HIV. So we have the highest rates of HIV-TB co-infection in the world. When you look at outside our borders, outside of sub-Saharan Africa, about 15% of individuals with TB have HIV. But here in South Africa, we have a substantial burden of co-infection, both TB and HIV co-occurring in the same individual.
Thank you for that context. Perhaps we need to look at the advances on treating TB and HIV at this point for those who are living with both. What does access look like, and what does that treatment look like as we speak?
Luckily, in South Africa, treatment for TB is freely available through the public health program. So you could walk into a primary health clinic, access a diagnosis for TB, and get put onto treatment for TB. We have two main types of TB in our country. That's drug-sensitive TB, which is treated currently with a 6-month regimen, and drug-resistant TB, which is being treated with a 9-month regimen, and we are hoping a shorter 6-month regimen will be available to patients with drug-resistant TB by the end of the year. There's been several innovations in both preventing as well as treating TB. A new 4-month regimen using different drugs. So 2 of the drugs are the same and 2 drugs are substituted, and they're different. Now can treat TB effectively and as effectively as the 6-month regimen within 4 months. So that is being endorsed by the WHO as of June 2021. We have not yet taken up the 4-month regimen in South Africa, as we have, as I've mentioned already, a substantial amount of patients that have both TB and HIV together. And we still need to determine whether combining the new drugs with the existing antiretroviral treatment regimen will make or undermine the ART regimen. So we still need to understand this a bit better before we bring them into our guidelines. There's been substantial gains in preventing TB. And so instead of taking 6 months, 9 months, or 12 months of INH preventive therapy, we can now very effectively prevent TB in people living with AIDS with 2 drugs taken for either a month or 3 months. So it's the isoniazid and rifapentine 3-month short course TB preventive therapy. So those are some of the latest advances in TB treatment and prevention.
Prof, thank you for the looking at the strides taken, perhaps also looking at some of those alarming stats coming through for the country. At this point, which population group is most affected? If so, why? And also why? What concerns arise as we look at South Africa, its health, perhaps also the future labor force?
So when you look at tuberculosis, it's really a disease of the poor, of the marginalized, of the homeless, of people with immunity that is not intact, like those individuals that are living with HIV. They are unable to protect themselves from developing active disease. South Africa is what we call a high TB burden setting, in that there's a lot of TB in our country, and many of us 60 to 80% of South Africans have what we call latent TB infection, in that we are infected with TB, but our immune system is able to keep the bug in check. It does not replicate and it does not progress to active TB. But if you are malnourished, or you're living in poor living conditions, or if you have HIV or diabetes mellitus, then your ability to contain the TB infection is very limited. And so your risk of developing TB each year is about 10-fold higher. So your risk for TB is heightened. And so your risk for TB disease is heightened. And so we need then strategies to better diagnose this TB or prevent the TB or treat the TB when it does occur.
Looking at the existing policies then, what is working? What is not working in your view against the fight, against TB, HIV and AIDS? What are the knowledge available, the knowledge systems, the attitudes at a population level that's contributing to these concerns?
Both HIV and TB, it's really about the perception of risk and coming forward to access a test. If you perceive that you may be at risk for HIV or TB, you need to present to a health service and request a test for HIV. Request a test for TB if you are displaying one of the symptoms of TB, of cough, fever, night sweats, unintentional weight loss. You may have TB, or they may be a close relative, a family member, somebody living in your home that was recently diagnosed with TB. If that is the case, whether or not you have symptoms, you are eligible to have a test as well as to be put on TB preventive therapy. When I reflect on the gaps in our health service, the biggest gap is failure to access a test, both for HIV and for TB, and failure to access TB preventive therapy if you are at risk, failure to access HIV prevention if you are at risk. PrEP is freely available in primary healthcare clinics. TB preventive therapy for high-risk contacts of patients that were newly diagnosed with TB is also freely available. Testing is easily accessible. And I think that given that we have the opportunities to test and prevent, the general South African public need to take advantage of it. We are in a high burden TB and HIV setting. We need to demand access to both diagnostics and prevention. If one has symptoms and they have not yet been diagnosed with either HIV or TB, a demand for a test is critically important.
Prof. Kogie, perhaps as we wrap up this conversation, I want to shine a spotlight on NHI, perhaps it's a rollout as well, in assessing its impact in terms of access and quality healthcare. Do you think this is in the best interest of patients or potential patients? Also at this point, what concerns arise as well?
So the biggest positive that's been driving the NHI is universal health coverage. Currently, health services are concentrated around the metros. So the busy metros have hospitals, they have primary healthcare clinics, they have GPs, they have diagnostic services. But if you move out of the metros and you go to more underserved communities, your rural communities, your informal settlements, access to services is very limited. So the whole concept of the NHI is to enhance coverage of services, both preventive services and treatment services. For the poor in the community, for the marginalized in the community, the intent of the NHI is to enhance access to care, to enhance access to diagnostic, prevention, and therapeutic services. The success, however, relies on the quality of services that are deployed and that it is actually accessible and available to the individuals that it is intended to serve. And I think that the concept is a brilliant one, but we have to ensure optimal implementation for us to realize its benefit.
Absolutely. Prof. Kogie Naidoo, thank you for your time with us here on the SABC, weighing in as the 11th SA AIDS conference gets underway, just speaking to some of the pertinent themes that are obviously emerging, touching on TB and HIV AIDS, co-infections, some of the advances in treatment, and looking at some of the existing policies, strides that have been taken that benefit those infected, but also some of the gaps in the healthcare system at large. Again, thank you to Prof. Kogie for her time.